Hi, everyone. Welcome. I would love to introduce our guests today. We have Dr. B, Danielle Valoras, and Robyn Towt. And my name is Terry Diaz. Welcome to our Facebook Live.
And we're going to just discuss a little bit about what is breast implant illness. And Dr. B, Robyn, and myself, we wrote an article, which I can pull up in a little bit. And it was published. What did I pull that up now? Real quick here. I guess nothing's real quick, but I will try just so people can see where they can get it if they want it. So you can see what we were talking about. Can you guys see my screen?
We can.
Yes, we can.
Okay, let me move the bar. But this, we wrote an article that was pretty extensive, I thought. I mean, we have about 90 references, and we actually pared that down a bit. And I know I wanted to use as many references as possible so that this would not be like conjecture or fake news. And we went as far back as like the late 1970s and the 1990s to get some of the descriptors in here. And one of the things that I gleaned in doing this research with you is how far back we started the same conversation about the impact of breast implants on most or some women. And I'm going to just scroll down just because I'm proud of the reference section a little bit.
And can you make it a little bigger, Danielle? Like on your keypad, can you, just so the viewers can see a little bit better if they're watching?
Yeah, maybe.
There you go. Yay.
And again, this is accessible as an article, I believe, as well as in a book, in the Advances in Cosmetic Surgery. And this is from May of 2023.
We also have it on our Breast Implant Health Summit resource page, and we have it on our, I believe, GPAC resource page.
Wonderful. So
if anybody has trouble getting a copy of that, if they want that, just you can email me or call the office. I can send you a PDF copy. It's not a problem. It may even be on our website now too.
Oh, wonderful. So just in brief, just so, because I know that there's going to be a lot of feedback of, you know, there's not these long-term studies. I mean, the manufacturers haven't really provided post-market studies and these kind of things. But the reason why I wanted the references and the bibliography to be so robust is to, one, prove longevity, that this has been chief complaint since the mid-70s, 1975, 1979. And then you see another surge in the 90s, and then you see another surge after 2006, and now we're seeing another surge now. And I wanted to make sure we put in context the review studies of silicone, the small lab studies, in vivo and in vitro studies that we have, and albeit some of these are small, but there's a lot of case studies that when you look at them together, and I think Colares et al. And Dr. Towt, like they've looked at all of these things to be able to like do a review / meta-analysis to say there's something here. And so at least we're making the definition that breast implant illness is real. There is something about it. And while some of us might feel like we know what it is, i.e. the breast implant, people are still looking for the particulars. So just for those of you who want a historic reference, there's about 90 references here. And you'll see a lot of work by Dr. Buinewicz and Dr. Towt and Dr. Capel and Dr. Dietzschman and Dr. Fleury here. So all of the data that's in here, the charts and everything are pretty much referenced, right? So it's not just us saying the things. And I think that's a big thing to be able to state. And I just thought I'd say that. The other thing I'd like to just dive in and look at what I'm calling the elephant in the room is ASERF, or the Aesthetic Society, has proposed a new name called Systemic symptoms of breast implants or something to that SSBI. And what I wanted to ask you what you thought of that. Like, it's not necessarily a new term, but when I search articles and I look at the keywords, I never thought to put SSBI up there, right? Like in all the literature from the 70s, you have silicone toxicity, autoimmunity implications from breast implants, breast implant illness, capsulectomy, things like that. Like those are the keywords that people will search on. So if you started to search on systemic symptoms for breast implants, like this article wouldn't show up, this reference point wouldn't show up. And so I'm curious what your thoughts are with the proposed name change from a plastic surgery society.
It's interesting. I understand their point, because if you're saying breast implant illness syndrome and acknowledging that, publishing that in any articles or whatever, you're pretty much saying that breast implants are causing illness. And in their joint advisory statement they just came out with, that was one of their points. We really don't, there hasn't been anything proven yet. And it's going to take a long time, a lot of studies to be able to find out what the causative factors are, what is throwing off people's immune system, that they have this chronic, immune system dysfunction that starts triggering systemic symptoms. It's going to take a long time to know that. But to rename things like precise capsulectomy, I understand that also. I mean, there's a problem with breast implants, and it's been around for a long time. And we know that historically from what we wrote in this paper. I mean, the reports going back into the 70s of people getting sick from their breast implants. So it's been around, it's been consistent. Doesn't really matter what you call it. It's just that people that have breast implant illnesses, breast implants in, can develop systemic symptoms from them. So call it whatever you want. It's a real thing.
Yeah. Robyn, what made you write this article or co-write this article?
I mean, I think ever since Terry and I have been advocating together, she's been in it 1 year longer than I have. We just see the same underlying narratives, right? We see the same narrative from the patient community that breast implants are making women sick, but we also see the same narrative from the plastic surgeon societies. And historically speaking, they've always been very dismissive, not just about systemic symptoms and breast implants making women sick, but even about the cancers that are caused by breast implants. I mean, back in 2011, when the FDA announced the BIHS lymphoma that's caused by breast implants, there was actually a joint webinar held by ASPS and ASAPS, which is now the Aesthetic Society. And the leaders of the societies were literally telling plastic surgeons to downplay this cancer and don't call it a malignancy, don't call it cancer, call it a condition. So we don't want to scare the patients. At the end of the day, it's cancer, right? And these cancers are horrible. And this joint announcement, I do want to point out whose name is not on the joint announcement, and that's ASPS. So ASPS is not pushing this narrative. It's clearly the Aesthetic Society and ASERP, which is their research foundation. And I think the International Society is on there as well.
Correct.
So I think the timing of it is really disrespectful to the breast implant illness community, considering the recent cancer announcement that the FDA has, they just issued an update in March of 2023. And I think most of us on this screen and many of the people watching have seen presentations about these cancers, and specifically squamous cell carcinoma, which is related to the breast implant capsules. If you look at the horrifying pictures of these patients that have this cancer, and then you look at this joint memo that's just kind of dismissing everything, or just change the name, and it's not that many people that are getting sick or getting the cancers. When you've seen the patients that have had to deal with this and what their bodies are going through, it's kind of a slap in the face. And for them to kind of push this narrative at such a vulnerable time, right after this FDA announcement, it just really shows the character of the Aesthetic Society to me. So that's kind of my take on it. Definitely not lost on me.
I can tell.
Yeah.
It was very interesting that ASPS did not have any type of statement, was not included. There have been ongoing, basically feuds between, ASPS and, ASAP. So, I don't get involved in any of that. I'm a plastic surgeon. I operate on people. I pretty much limited to that. I'm not involved in any of the committees on either of the ASPs or ASAPs. I'm a member of both societies. I go to the meetings, I attend their webinars and all, but I'm not a political person, to put it that way.
Yeah.
Well, and I think that's an important piece of the puzzle as well to point out is the people that are in those leadership positions of that society have continuously been in leadership positions of not only that society and the research foundation. So they kind of control the puppet strings, if you will. And it's just, it's very obvious that they're obviously not as connected with the patient community as ASPS. We've all worked very well together with ASPS. They've been very welcoming to us. They've lended a listening ear to our problems and what we're experiencing in the community and kind of what we're asking them to help us with. So we really appreciate, just their willingness to work together and collaborate. And
Well, they worked on the checklist with us too. So
yeah. So we appreciate that collaboration. I mean, that's really, that speaks to their character as well, and the leadership, that they see what's going on, they see there's a problem, and they want to help us. So we appreciate that for sure.
No, and I agree, and I get it too. I mean, so when you come to, nobody likes being told what to do. And, medicine is not just evidence-based medicine. I mean, you have to do research. You have to have a hunch, a suspicion that, there's something going on, say breast implant illness syndrome. I have my patients, I take their implants out, I perform a total capsulectomy on these patients, they get better. I can do it safely. I've done this on many, many patients. So there is definitely something to this. I mean, I wouldn't keep taking implants and capsules out on people if I was having high complication rates or I didn't see my patients getting better. And then of all the, different operations that I perform, this is the highest patient satisfaction group by far. And you have 95% of people that come back, getting their lives back, that their lives are changed because they've taken their implants and capsules out.
Yeah, from symptoms diminishing to actually going all away and being
completely going away. A significant number, probably close to 70%, completely resolved.
Yeah.
I mean, one of the most fascinating things is migraines. You have people coming in having 2, 3, 4 migraines per week, which are debilitating, and they get their implants out and their migraines are gone and they stay gone. They don't come back.
It's intriguing. I know we're veering off like the header of the topic, but in my world, in my context, I don't even know why we're having a conversation about partial versus total capsulectomy. Certainly you want to keep the patient safe. Correct. And certainly in an experienced hands, your adverse events and your complications are going to be less, right? So that's Correct. Why I would search out someone who has a decent amount, if not the most experience explanting. And I would favor referring to that type of person and going to that type of person. When cancer is potentially in, even if it's rare, in a capsule or an inflammatory object like a capsule or a scar tissue that is inflamed like a capsule, like I just don't understand why we would leave it in, aside from they can't get it off the chest wall because of patient safety. I don't know why we would want to even try to leave that in. And I'll give a quick scenario. I have a friend who had a prophylactic mastectomy, got it in implants. She ended up with the textured implants. And then she finally decided to take the implants out. And she thought, you know what, I don't want to have implants in me. So she chose to have a deep flap, right? And I told her, let's make sure you get the capsule out so that, you don't have any issue with that. I call it the catcher's mitt moving forward. And her doctor said, well, we don't necessarily have to do that. And since you want it, okay, we'll do that. And so they did, and they sent the capsule to pathology. And if they hadn't have taken out that capsule, she would not have known she has invasive ductal cell carcinoma. And that's not even, we're not even talking like SCC or lymphoma or things like that. It's like other things can grow in this environment. And so why wouldn't you take it out?
I don't know why. I mean, from
Yeah,
my standpoint, it's chronic inflammatory tissue, related to having a foreign object inside of you. I mean, I do this or used to do this when I treated people with pressure sores. You would never take somebody with a sacral or ischial pressure sore from, paraplegia or whatever reason they have a pressure sore, leave all that chronic capsule scar tissue in there and just close the skin on top. You're doomed for failure. So you want to get rid of that chronic inflammatory tissue. You create an acute wound bed. That's the best way for wounds to heal. If there is something in that capsule, silicone, heavy metals, bacteria, fungus, whatever, you've done the most important thing. You've debrided that wound and treated it appropriately.
yeah, agreed. So, Dr. B, what would you like people to know about breast implant illness, or what would you like that someone who's just listening to this to understand breast implant illness? What would you say in like layman's terms?
From my standpoint, this is the way I describe it to patients is that this is, you have an inflammatory condition. You put a breast implant or any implant in somebody there, you've made an injury, there's going to be a wound, there's a healing process. And the difference with having a foreign object inside of you, whether it's a breast implant, a pacemaker, whatever, your body's going to react to that foreign device, and it's going to make that layer of scar tissue around it. That we call them capsules and breast implants, but it's scar tissue. That scar tissue is living tissue. You have blood vessels and lymphatics are there. You have a localized chronic reaction with lymphocytes and macrophages with that foreign body. And in some people, and probably most people, once we ever know percentages, it stays a localized process. You have other people that for whatever reason, that localized process, those, inflammatory cells, the modulators, the interleukins and all, they're all systemic. The body's exposed to them. And now you start getting that immune system response that's affecting other parts of people's bodies. And that's breast implant illness syndrome. And the best way I was able to describe this is during COVID. And you have people that got COVID and, it's a coronavirus. I mean, they just had basically mild symptoms and illnesses. You had other people that had catastrophic problems where they got multi-organ system failure. People died from it. I mean, there's reports the same thing with the vaccines with that spike protein causing, similar reactions. It's rare, but there are definitely reports out there. So same thing. There are some people that can handle these things well. Other ones that no, they crash and burn. And that's what happens. I mean, it's an inflammatory response in somebody's body that's now getting out of control. It affects every organ system in the body.
And removing.
You get rid of that foreign body. I mean, that's the first step to getting better. If you take out that inciting thing, and again, most of my patients that I see, fortunately, have had a full, they've had multiple medical workups. They've gone through the process 5 or 6 times. They see their primary care doctor and they get worked up for their symptoms of joint pains, fatigue, headaches, or whatever. Can't figure it out, come back again, still complaining of joint pains. They go see a rheumatologist. They rule out rheumatic diseases. They run more blood work. Most people have already done their workup multiple times.
Yeah.
They know that they don't have a benign disease process or something dangerous that's causing the symptoms that they're having. And they're left with people, what's obvious. I mean, it's, that they're have 2 foreign bodies inside of them. And could they potentially be causing this? There's no medical device that we put in a human being that lasts forever, that doesn't wear or deteriorate. Right. So why doesn't that apply to breast implants?
And why not give them the best chance to heal? I mean, if they're coming in and want their implants out because they're sick, and that symptomatic behavior in their body, that inflammation in their body isn't localized, it did go systemic, why not remove it and give them the best chance they have of healing? I mean, I feel like to leave it in there, you might as well leave the breast implant in there because they're still going to have a response to that capsule.
It's true. I mean, I believe so. I mean, I take the capsules out completely. It's a total capsulectomy. Most of the time you do. It's a technique of performing the operation. Whenever you're operating on tissue, if you watch YouTube or whatever, you're always putting tissues on tension. That way you can safely find a dissection plane and perform the operation safely. If you got paper thin tissue or very inflamed tissue, it tears. And once you get even a microscopic tear, you're not doing an en bloc capsulectomy, but you can still remove everything completely. Capsule, it's chronic inflammatory tissue. It looks very different than normal healthy tissue. To leave it behind, you have to close your eyes.
Yeah.
Well, what I find interesting is my niece had a port in because she had cancer, and when she had it removed, her doctor said immediately, we'll make sure we remove the capsule. Like, it wasn't even a question. It's part of the procedure. And I didn't understand why it's such a argument in our community in this process.
I mean, same thing I tell my patients. I mean, capsulectomies, it's not a new operation. It was not invented for breast implant illness syndrome. Capsulectomy was done for complications from breast implants. And looking back, into the 70s, when people had ruptured silicone implants, the original liquid silicone inside those implants, or a bad Baker grade 4 capsular contracture, we were taught as plastic surgery residents, you do a complete total capsulectomy. You cut that out, get back to normal healthy tissue, and then if you choose to put an implant back in, put an implant back in, but that's what you do. So it's not a new operation. It's something we've always done. It's tedious. It takes time. And yes, you have to be very careful, and because you can have complications. Getting that capsule off the chest wall, between the ribs, those intercostal muscles, you got 3 to 5 millimeters before you're in somebody's lung cavity.
Yeah.
So you have to be careful.
And you need the experience. I don't know how many do you think someone needs to have done before you feel good? Say, like, if you had residents, how many,
How many? You
so
learn
for those docs who still implant and explant, right? Like, it's going to take them longer to reach their number of, like, to do 100. I mean, there's some N in which
there's no way you can put a number on it,
yeah.
because as a doctor, as a surgeon, I learn every day, and I see things every day. You have those sphincter tightening moments in the operating room, so you always keep learning, and you always keep getting better and better. It's like playing a musical instrument or practicing a sport. The more you do, the better you get at it.
Yeah, agreed. What I found interesting, and I think Dr. Flory called my attention to this, is I was going through the different IFUs, the instructions for use or directions for use for each implant manufacturer. And what's interesting is I think it's actually the Motiva one or maybe the Mentor one, where they say, and don't quote me, but do read everyone's IFU, which may actually be all of them in the reference of our paper, but they say, if you're going to replace, I'm paraphrasing, if you're going to replace the implant, make sure you remove the capsule, the scar tissue, because if you don't, it could impact the new implant's half-life by 50%. So it's in the context, I think, of capsular contracture. So when replacing, in order to not have that 50% decrease of that implant, you should remove the capsule. So how that landed for me when I first read it was that even the manufacturers on implant change out, do you call it change out? Exchange. They say take out the capsule because it can interfere with your new implant.
I would have to see that. That is very interesting, for sure.
Yeah, and I think I have it highlighted in Motivas, and Mentor says it in a different way, but it's quite, and it depends on which year IFU as well, right? So
It'll be interesting to see what they reference that to.
Yeah.
And why that statement was made.
Yeah.
One thing I did want to say, with doing this, chapter, the Understanding Breast Implant Illness, it was a pleasure and an honor working with both of you doing this. It was a ton of work, but I think it's one of the few publications that's out there where we were able to pull in not just surgical, publications. You have rheumatologic, you got radiographic studies. You're able to pull it in from every specialty. Yeah. And that's what you see, and that's what people have to look at. You can't just be telescoped into your own single profession or whatever. You have to look at other places for things. And that we were able to pull this together, which is important.
Yeah.
I love that, and I agree with it.
Yeah.
100%.
We say that all the time.
Yeah, and I love that. That's why we called it Understanding Breast Implant Illness, because when I was at ASPS in October, Danielle and I were there, we spoke on a patient panel, and I encourage plastic surgeons, and I think this might be part of the problem too. I encourage plastic surgeons to, if they really, really want to know about breast implant illness, you have to look outside of plastic surgery journals.
Correct.
Because there is a whole world of information, studies, scientific evidence that we successfully pulled together in this chapter, which was I feel like it's our baby because we pulled it all together. We pulled all of that, and it really does give it a big overall picture. So I hope that people understand that and they're willing to read it and give us their feedback, because I think we did a good job being very comprehensive.
Yeah, absolutely. And it's a big step, forward for the research that needs to be done. But again, too, the whole field of immunology, I don't think became a recognized medical subspecialty till like the 1990s.
Yeah.
So, this whole understanding the immune system, we still don't understand it completely by far. This is all an immune related process. Can there be genetics involved in all that? Absolutely.
Sure.
But, it's all in its infancy.
Even just what inflammation causes: chronic inflammation, heart disease, chronic inflammation, high blood pressure, chronic inflammation, diabetes, chronic inflammation, blah, 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 blah.
Exactly.
And this is a source of chronic inflammation in my world. And so then what's next? What's the next cascade? I think for me, for anyone who has breast implants, I think they should tell their provider they have breast implants, and that this could be one of the reasons of the symptoms. It doesn't mean it is the only cause. It doesn't mean it doesn't even mean they have to come out right away, but it should be in that differential. And I hope people will look to that sooner, so that way, while we're looking at this as like a diagnosis of exclusion, to go to this doctor and they say you're fine, then okay, then let's check this doctor, and they say you're fine, and then this doctor, and then you're fine, and this doctor, you're fine. I think I went to at least 12 and I was all fine. And then that's when I could get my implants out. That was a year, right? I could have had my life back earlier.
Right. By
So
far.
I hope that collectively we can all have the conversation of, what could it be? Like the studies, yes, but I don't like the way that it's written in ASERF. I think the person should be checked out. Absolutely. I think they should be worked up. Absolutely. Make sure they're safe candidates for this surgical procedure. This is no longer, in my world, a cosmetic procedure. This is a therapeutic procedure. These are ill patients getting on their tables. I would be nervous if I was, them too, and making sure that patient is as healthy as possible. But these people are sick.
But yeah, and again, that's what any board certified plastic surgeon should do, is to make sure that what they are, their preoperative diagnosis, this is what they think the patient has, that they've ruled everything else out, so that their postoperative diagnosis matches that, and the patients get better. You need to have that. It's all common sense. It's all part of the whole process, working somebody up.
Yeah.
And if you get somebody that's got soft symptoms, or you're not quite sure, they need to know that ahead of time. This may not work for them. And it doesn't work for everybody. There are patients, really, they're very slow responders, slow months to years out before they potentially can see changes, and other ones don't.
Yeah, when I look at the data, it's interesting because everything says 10 years, 10 years, 10 years. And I was 3 months and I had mine out in a year and 9 months, right? So there's got to be another subset of population, or we need more than 40, 50 people in a cohort to see what that could be. Did you, not to put anyone on the spot, we interviewed Dr. Diva not too long ago, and he showed women with implants, no symptoms, women with implants and BII symptoms, both on explant improve their health. Mm-hmm. Both. They didn't know that they were fatigued until the implants were removed. They didn't know that, their ADHD would improve until they remove their implants. So I found that quite.
I'm definitely seeing that more and more with patients coming into practice that basically they've had implants in for 10 or 15 years. They see what's happening. They want them removed. They're at a different point in their life and they don't need their implants anymore. It is interesting that, you know, just mechanically getting the weight off their chest to having that implant in there. I mean, they're not benign, light things. Getting all of that scar tissue off the chest wall, if they're submuscular or partially submuscular, they notice those mechanical changes for sure. And then other things usually.
Yeah.
Well, and I think it's a little concerning for me too. I was very lucky. I only had my implants in for 4 months because they made me that sick that quickly. And I had mine for breast cancer reconstruction. Didn't have chemo, didn't have radiation, didn't have any other therapeutics. So I couldn't understand why I was so sick. I mean, I felt like I was in the middle of chemo. And all these other breast cancer ladies that I was talking to were like, oh yeah, I have migraines too. And I have that too. And it's from chemo. So luckily I figured it out quickly because the only thing that I changed is I got breast implants, you know, after my mastectomy. But like Terry, how many doctors did you see over how many years?
So many, like over, I would say like 40. We spent well over $100,000 on medical bills, like my copays.
Yeah.
And many multiple doctor visits, different things that we tried. And I mean, I lost 10 years just because not one person would say, hey, I think it might be your breast implants. It's one of the reasons why I fight so hard in advocacy is because I just don't, it frustrates me that there's a narrative out there that breast implants don't make you sick. And they did, because I couldn't even walk up a flight.
You have to prove it, Terry, by going to 100 doctors and getting 120 different tests and diagnosing it through exclusion. We've excluded everything else, then maybe it's your breast implants. It's like, you know,
I was literally on my deathbed, went into that surgery, and I didn't get better right away. I wasn't one of the, but I could breathe, first of all, and I felt like there was a sliver or something out of me. Like I felt like a response of like a relief that I can't really explain. And it only took me, because I couldn't walk up a flight of stairs before I went to surgery. I was that sick. And after surgery, it took me like a week and I could walk up my stairs. And that's when I knew. I mean, it, you know, it took me a while, but that's it. And now I'm back to being pretty healthy. So.
And again, yours is not the only story, but that is, it's a shame what people spend on top of putting implants in to get all these workups and everything done just to finally get to the point that it's probably the implants. It's crazy.
And it's not that I want this as an option for people, but if you remove them, wait a year, and you're not happy with how you look or whatever, then you've got, at least at that point, you've got choices. And then you've excluded it being implants or not implants or that kind of thing. Like I would like to see people, I don't want to push them to explant any faster, but I want them to know that, you know, it could be perimenopause, it could be your implants, it could be arthritis, it could be your implants. Like I want that in that conversation so people can look at the.
And again, I mean, they're not a lifetime device. Yeah. And the longer you leave them in, the more chronic inflammation you're going to have. And, you know, like the rare cancers and lymphomas, I mean, these implants have been in 10, 20, 30 years. That chronic excessive inflammation over time, then you get cellular mutation. So yeah, I mean, you know, to change that paradigm, change the way you think about it, to, you know, when you get to that point, take the implants out. It's one of the few operations that we do that you can almost completely reverse. And you can't, it's hard to reattach that lower part of the pectoralis muscle. You release down by the rectus fascia. There can be some, I mean, obviously there's going to be changes in the breast skin, the quality of the skin, the elasticity, breast tissue, but you're pretty much back to where you were and reverse the operation.
Yeah, my brain just jumped to MRI. You know, I forgot to add that in here where if you read the IFUs like I do on my day off, no, I'm just kidding, which I do, but
yes, you do.
Let's just
doesn't everybody read the IFUs?
Doesn't everyone? So last year was SSEDs, now it's IFUs, but all the manufacturers say get an MRI at 3 years and then every 2 to follow. And then the FDA says this is Ellie, get an MRI at 5 years and then every 2 to follow. And so I find it interesting, like we could be doing this just even to look for implant rupture, which then would an MRI give you any support in the OR at all? Like if you knew something was ruptured, would you use, if you can't end block, would you use a different suction device, or like?
It depends. I mean, it depends on the age of the implant you're putting in. You know, if it's one of the newer generation cohesive gel implants, you know, 4th or 5th generation cohesive gel, even if you tear the capsule, it's contained. You can easily see that you're in the capsule, you got a ruptured silicone implant, you don't have liquid silicone oozing out. It's very easy to square off and protect the tissues, evacuate that ruptured implant, you know, clamp and seal off the capsule to complete doing the operation. It's much easier doing a total capsulectomy with the implant out of the capsule versus in it. So, I mean, it would be helpful. It still doesn't change my game plan that it's nice to know you have a rupture ahead of time so you can try to stay away and not get into that capsule. But if it happens, it happens. You have to know how to, you know, get rid of that silicone so it doesn't spill into somebody, just even mechanically. It's a mess. And then you complete the capsulectomy. And the biggest thing is who pays for these MRIs? I mean, they could say, geez, get the MRI at 2 years, 5 years. If anybody's been to their doctor when they had implants in, it's next to impossible to get an ultrasound without a mammogram. Most places will refuse to do that. And if you're worried about a rupture or having pain, you know, why would you want to go and have a mammogram done? You're not looking for malignancy. You're looking to assess implant integrity, but they won't do it without a mammogram. And then you get the ultrasound, and every radiologist covering their tail is saying, you know, not the best test by far at all. You really need an MRI.
Yep. And then, so for all those listening, get a breast implant integrity MRI with contrast. That gives you the most sensitivity and specificity. Some of us can't tolerate the contrast, but get that breast MRI anyway. As we're beginning to teach the world how to read for that silicone-induced granuloma within the breast implant capsule, like with Dr. Fleury, and I believe Dr. Fang actually does that in her ultrasound. Her radiologists, they read for it regularly all the time. So any other thoughts on how to understand? What would you like other physicians who are just becoming breast plastic surgeons, and I'd like to say breast versus just breast implant, because there's so many procedures now that you can do that you don't need the breast implant to have someone look as they might like.
It's for the younger plastic surgeons, the residents, to at least, you know, have their eyes open. Just because we don't have, you know, evidence-based medicine literature, significant amount that's out there that you can say, okay, well, here's, you know, a 10 prospective randomized trials that show that yes, breast implant illness is a real thing. Because we don't have it, it doesn't exist. At least, you know, keep an open mind, and you got to add with your patients. You know, if somebody has an implant in, breast implant, any implant, and has these problems, that could be what's causing it. You went through these with the cobalt hip prostheses. I mean, you know, nothing's perfect.
We go through that with dental implants too.
Absolutely.
And IUDs and
mesh.
Mesh. Oh,
Yeah.
That's just a whole nother ballgame. Yeah.
I was like, that's a whole nother live we can talk about next time,
yeah.
which I would like to.
Wonderful. Terry, would you like to check to see?
Do you know how many people that I see with breast implant illness syndrome don't realize that their IUDs are coated with silicone?
Yeah.
And still have them in?
Yeah.
Yeah, I make them get them out. Yeah.
And some have copper, and talk about that zinc copper ratio. Like it's crazy what some bodies do with some things, you know. And what was brilliant about the IUD is it is it's not an implantable device. It's a pharmaceutical. I think that's how they got it approved, right? So, and its main job is to cause inflammation so you don't get pregnant.
Exactly.
It's you know, the perfect storm. So anyway, so Terry, is there any?
No questions,
Okay,
no comments.
Any last thoughts for people before we sign off?
Again, I wanted to thank everybody for all the help in getting this published. And again, for things like this, that just, you know, common sense discussions out there. I mean, I do get the joint advisory statement about doctors on social media calling them experts. You know, to be an expert, you got to have the knowledge. and you have to have the skill. And, you know, I don't consider, I consider myself experienced, not an expert, put it that way.
Yeah. I think any physician or anybody in a professional status who is on social media should be able to speak to, at a minimum, the FDA guidelines for
Correct.
whatever product they're using out there. But to use it as advertisement and selling, I think we're running into a world where there's got to be accountability for some of the statements that are said, because there are younger, older generations, all sorts of people from everywhere listening. And I think it can be harmful when people say, no, breast implants are fine, they are not dangerous. To make a statement like that without saying, and the FDA has a, box warning about it, and there's recalls on it, and there's been controversy around it since, 1980 or whatever, 1990 something, or to be able to say that, Dow Corning lost their lawsuit against silicone because of the breast implants, because of the silicone and the free silicone and all of that. Like that should be weighted right after, like the next wave or the tidal wave out of that person's speaking.
Interestingly, when I see patients, and it's not common at all that I see patients that want an augmentation or considering an implant, I tell them about the risk of getting cancers and dying from those cancers, the squamous cells for sure. I tell them about breast implant illness syndrome and that their life can be significantly impacted and they may not potentially get better. The known complications of capsular contracture, ruptures, infections, things like that. The only thing that makes people think twice, because everybody nowadays, it's not going to happen to me,
right,
is when you factor in that they're not a permanent device. And if you think that every 10 years or so you're replacing that implant, you start factoring the cost, that's when they'll start to slow down a little bit.
Yeah.
That, you're talking about spending a significant amount of money and things, for something that can have significant complications.
Well, and if you look at the manufacturers, they're actually telling you this is our AE rate. At 4 years, we could pull up the chart, like depending on which group you fall in, a good 7% of people in the reconstructive revision group are going to have a silent rupture.
Mm-hmm.
You are then dealing with free silicone. Right. And then the way they did the MRIs way back when, it wasn't like the 1.5 Tesla now, like you couldn't see the ruptures. So I'm assuming the rupture rate is actually higher now. Right. So it's like these things do happen and there is an impact. And for those people who say, I still want it anyway,
but at least they'll know. And then when they get sick, because they won't lose the years I did, because if I would have known when I first got sick, I would have been like, oh yeah, I remember, it's my implants.
Yeah.
Let's take them out.
Yep. Game over.
Yeah.
And, it's interesting because there is, to my knowledge, no other product on the market. There's not a car on the market, a medical device, a drug that has this kind of failure rate and is still on the market. So it's just interesting, but that's where informed consent is truly the most important thing here, because there are women that are willing to take the risk, and as long as they know, so that when they start seeing symptoms, they don't have to run around like Terry did for over a decade, spending hundreds of thousands of dollars on testing to try and figure out what's wrong with them.
Yeah.
So we just want to normalize that conversation, and I think writing this chapter like we did, I think that's all part of it. So
yeah, thank you for allowing us to work with you on that. I very much.
I'm proud of all three of you.
Thank you.
It was fun, but it was a lot of work. Thank you both.
Yeah, it was an honor. Thank you for inviting us to join you on that.
So anyone still listening, please put your comments and questions in the Facebook Live section, or the comments, I should say, and then also on YouTube, and we'll get back to you as soon as possible. But we're going to end this live, and we'll say to be continued for next time.
Thank you, Dr. B.
Thank you.
Thank you.